I think we can start. Welcome, everyone. Good morning, good afternoon, good evening, wherever you are. Welcome to the 8th meeting of this monthly webinar series organized by European Society of Neurogastroenterology and Motility and Turkish Society of Gastroenterology, entitled Speed Date with Experts in 60 Minutes. It is exactly 60 minutes. We have distinguished guests today, but before that, let's summarize what we have done so far about the previous webinars. That's, as I said, we have 7 previous ones. Can we show the previous slides, please? Yeah, we started on October with talking about the IBS on IBD. In November, we talked, that was a different topic. We mentioned the eosinophilic esophagitis. Afterwards, reflux disease. And then that was the first 3. Then we moved to the abdominal bloating and distension. Is it a nightmare? Yes, it is a nightmare. We will see more about that tonight. And afterward, the achalasia and the synergic defecation. How do we hold into stool? And what happens if we can't, if it let it go? That was another point. And after all these points, you know, now, we are here in order to talk about microbiota and functional bowel disorders. As you know, in our program, we have a basic or translation science study, we have a clinical science study, we have a case presenter. And each presenter is going to present within 12 minutes. And during the presentation, please write your questions under your screen. You will see question answer session, question answer part. Please write over there and let us know. And I'm going to ask the speakers your questions. Let's start with Tarkan. Tarkan is from Turkey, from Gazi University Faculty of Medicine Hospital. And he's a very well-known name in the field of probiotics, prebiotics, and microbiota. And he's the president of Turkish Probiotics Association. He's going to present his own and very interesting word, diet in IBS. Let's artificial intelligence decide what to eat based on microbes. Tarkan, are you serious though? Really? Artificial intelligence will decide about that, and then when I go to the restaurant, and artificial intelligence is going to tell me, okay, I'm looking at you guys, and you must eat this and that. Scary though. Go ahead, please.
Yes, it's scary, but I hope in the future it will be more or less better than today. Now I will share my screen with your permission. Yes, I'm sorry, just a minute. This and yes, I think you can see my screen.
Yes,
everything is okay. Okay, now I'm starting. Actually, this was our recent published paper about this concept, artificial intelligence-based personalized diet. It looks like a science fiction, but actually it is a preliminary or a pilot study on IBS. You know that certain diets can be used to manage functional GI disorders. There are lots of diet-related studies, clinical studies in the PubMed. Although personalized nutritional therapies targeting gut microbiota using artificial intelligence promises a great potential, this approach has not been studied in patients with IBS. In this study, we investigated the efficacy of AI-based personalized microbiome diet in patients with IBS with mixed form. And actually, excuse me, let's move this. In this study, we enrolled 34 patients, and 15 of them was the control groups that was given standard IBS diet, and the other intervention group, which was 14 patients, were given microbiome-based artificial intelligence assisted personalized dietary modulation. How did we do this? First of all, at the beginning of the study, we collected the stool samples of these patients, and we have analyzed the microbiome with next generation sequencing, some analysis, and then these data were also further analyzed by the artificial intelligence system using an algorithm. And then after these results, this group, the study group, received each patient received a personalized diet according to their microbiota profile. And at the end of the study, the IBS symptom severity score, there was an improvement in the symptom severity scores, and also in the quality of life, and also in the pain severity. We can look at it in a deeper in these slides. When we look at the microbiome analysis at the family level in IBS patients, we have seen that Ruminococca and Clostridia were changed, especially Ruminococca increased and Clostridia family is decreased in IBS. And when we look at the genus level, we can see that Ruminococcus genus is increased and Faeculobacterium is decreased in IBS. You know, Faeculobacterium prausniusi is a very famous bacteria, especially in inflammatory bowel disease and also in IBS and some functional disorders and metabolic disorders also. And there was also the microbiome score. This microbiome score, we don't have time to go into the deeper definition of this score, but as a result, the microbiome score means the lower the score, it is the more healthier. And when we look at the controls and IBS patients at the beginning of the study, we can see that microbiome scores were lower in the health controls and higher in the IBS patients. And when we look at the IBS symptom severity scores before and after the intervention, each group, the first group was personalized nutrition, the second group was control. When we look at the pre and post intervention, the IBS scores were decreased in both groups, but the decrement of the personalized nutrition group was much higher. And when we look at the details of the subgroups of the IBS symptom severity score analysis, we can see that in the personalized nutrition group, nearly all of the subgroup scores were improved in the personalized nutrition. But in the control group, only abdominal pain and distension were improved. Especially, for example, IBS-related quality of life didn't change, or dissatisfaction with bowel habits didn't change in the control group. And when we look at this graph, the IBS symptom severity scores pre and post intervention in the personalized nutrition group, you can see that in the post intervention, there is a higher decrease in the IBS symptom severity scores in the personalized nutrition group. And when we look at the subgroups of the scoring system, we can see that the pain frequency, distension, dissatisfaction of bowel habits, and quality of life were all improved in the personalized nutrition group. And pre and post intervention, when we look at the control group, this is not very highly improved in this population. There are some only figures. There is, for example, pain maybe a little bit, or distension a little bit improved, but more or less the other subgroup parameters were not changed. And when we look at the Faeculobacterium relative abundances for the study group, pre and post intervention, we can see that Faeculobacterium levels are usually increased in most of the patients. And when we look at the microbiome scores for personalized nutrition and the control group, we can see that in the personalized nutrition group, the microbiome scores are much higher, improved in this population, but it is not very much it is not very apparent in the control group. And lastly, when we look at the IBS symptom severity and the microbiome scores as a correlation, we can see that the IBS symptom severity and microbiome scores are positively correlated, and together there's a higher rate of correlation between these two parameters. Yes, in conclusion, actually, this is a very preliminary study, actually, because this is the first trial in the literature comparing the therapeutic effect of artificial intelligence-based personalized diet for patients with IBS. This is a mixed form. It is not diarrhea or constipation. We had clinical and gut microbiome level improvements after 6 weeks of intervention. Actually, the time period is a little bit short, I know that, but in this short time period, we have seen both clinical and microbiome level improvements. Of course, we need further larger randomized controlled trials to show the effectiveness and durability of this treatment. At the end of study, we can say that AI-based personalized diet modulation of gut microbiota is a novel approach for IBS treatment. In the small sample size study, AI-based diet is superior to control diet in IBS symptom improvement, and AI-based microbiome modulation might be a novel approach for functional GI disorders. However, we need, of course, larger trials to reach a solid conclusion. Thanks for your patience, and that's all that I will present. I hope we have questions and discussion. Thank you.
Thank you, Tarkan. You are pretty fast, my friend. We have enough time to discuss your results. Let me cough the one. Do your patients know that their diet actually arranged by artificial intelligence, or they were all blinded to the therapeutic approach?
They were all blinded, actually. They were all blinded. We will give you 2 other diets, but we didn't tell them about artificial intelligence.
How could you get this artificial intelligence program? Is it custom made or commercially available?
Yes, it's actually commercially available after this study, but actually this was, first of all, it was an algorithm that was originated, and then this is the one of the first human studies on this algorithm, but it's commercially available.
Commercially available for other indications as well, or just
for other indications? Yes, for other indications also. The company, this is a startup company, small company, or they are trying to increase the area of their therapeutic interventions, for example, in constipation or in diarrhea or abdominal gas, etc. There are some other areas they are using now at the moment.
Yes.
May I?
Sure, go ahead, please.
May I also have a question this time?
Please, we have time. Go ahead.
Yeah.
Tarkan, really, I liked your presentation. Congratulations for this tremendous start in a pioneering field.
Thank you.
I would like to know, you said standard diet in IBS, the control group. And I understand it was IBS-M type, but what
Yes.
means standard therapy, low FODMAP or something else? And the second part of my question, what meals were different between the 2 groups in a raw way, so grossly said?
The first one is that in the standard IBS diet, that was a modified FODMAP diet, actually. It was more or less a FODMAP diet. We thought a lot about on this issue, actually. This is a very difficult point, but we decided to give them a low FODMAP diet, actually. Of course, this is a very hard study because it's very difficult to show the difference between low FODMAP diet and a personalized diet. They are very similar, actually. What is the difference? The answer is it depends on the patient, because this is a personalized diet. Every patient had a different kind of what can I say, a composition of nutrients according to their microbiome profiles. some of them had, for example, according to the bacteria, if some kind of bacteria is low, we look at the literature and find out which foods are increasing that bacteria. Then we combine it. A dietitian, of course, makes this composition. After the dietitian makes the composition and calculates the calories, etc., according to the patient, and each patient has a unique diet.
Tarkan, there is a private question asking, can other scientists also work with this startup company? What is the name of the company? Maybe you should answer this question in a private base from the Q&A part of the,
Yes, of course. Yeah, I can.
Yes.
After that, I will.
Is it a Turkish company?
Right. Yes.
That's a Turkish company.
Turkish company, yes.
And one last question, how did you determine that which food actually changed the which bacteria? How could you determine that?
We made a long list of publications about the food items. We get an help and assistance from the dietitians. They analyzed all the PubMed, the publications. For example, there are lots of clinical studies on diets. And after that, we have found that, for example, this food composition increases this kind of bacteria, etc. A large study, a search, after a great search of the PubMed, I can say.
Lovely. Fransisco or Dan, any more question?
Very, very interesting study. So I think I'm looking forward. I know it's going to be presented at DDW next week in Chicago. So yeah, it's a good paper.
Thank you very much.
Okay, thank you, Tarkan. Now let's move to our clinical study coming from, that's about the intestinal microbiota and IBD, actually the gut microbiota composition in long-term remission of ulcerative colitis. Fransisco Guarner, he's a consultant of gastroenterology at the University Hospital Walda Hebron and senior researcher at the Digestive System Research Unit in the same place in Barcelona, Spain. And also Fransisco is a very well-known in the field of intestinal microbiota as well as IBD. Thanks for joining us, Fransisco. Looking forward for your presentation. Please go ahead.
Thank you, Serhat. I'm sharing my screen and starting the presentation. Thank you very much for the invitation. So this is a topic on IBD, particularly the focus is on ulcerative colitis. The study was on ulcerative colitis. And the study now is published in Inflammatory Bowel Diseases, the journal on IBD. And it's available online since April 10th, so only 2-3 weeks ago. So the thing is that in IBD, it is well known that the enemy is within the fecal stream. This means that investigators back in the 80s and 90s, they already knew that by diversion of the intestinal stream, the isolated loop it would enter into remission. So there will be healing of the mucosal ulcers if you have, for instance, an ileostomy in patients with ulcerative colitis. So avoiding the contact with the intestinal contents was healing. And therefore, they were thinking that bacteria were having an important role. However, it was very clear that bacteria were not causing the lesions. It was the response against bacteria causing the lesion. And this is because we know that by immunosuppression, the stronger is the immunosuppression from aminosalicylates to anti-TNF or anti-integrins, is the higher is the mucosal healing. So if bacteria were causing the damage, then by immunosuppression, we would increase the damage. So we know that bacteria stimulate the inflammation, but the immune system is causing the exacerbation. And then the point is that changes in the gut microbiota in patients with ulcerative colitis or Crohn's disease are still there even during periods of remission. This was our paper in the meta-hit study some years ago, where we compare patients on remission with ulcerative colitis with healthy controls. The controls were matched controls for the Crohn's disease and the ulcerative colitis patient. And each dot is the composition of a fecal sample in any of these patients. So they are different from their families. So still under remission, there are changes. And this was very clear. Some species are more abundant in health. One of them is the famous Akkermansia mucinifera, but many of them are fermentative species. Here you can see the abundance of these species in healthy, unrelated healthy controls, or in healthy relatives, or in patients with ulcerative colitis on remission, either in long-term remission or short-term remission. And we saw that there were less of this fermentative bacteria and more of all other bacteria. These species are more abundant in ulcerative colitis. And these are many oral species like the Peptigostrocus tomatis or Fusobacterium or other Collinsella, other species that might stimulate inflammation. So our study was to check differences in 4 groups of subjects, either patients in long remission of 4 years, after 4 years of a flare, of the last flare, in short remission, so between 3 and 12 months of clinical remission, and with normal fecal calprotectin. Here was also a normal fecal calprotectin, and a normal endoscopy as well. So we have also endoscopy of these patients. And here, patients during flare, which is a colitis activity index above 4, and an increase, as well as an increased fecal calprotectin. And interestingly, what we found is that during flare and during short remission, is a reduction of the richness, the cow index, or the diversity, which is the Shannon index, as compared to healthy people, or and here is unrelated healthy people, or those people in long-term remission. It looks like that just after the flare is a drop, and then it's a slow recovery pointing towards normality. And the same you can see in the Shannon index. And when you look at beta diversity, so difference in the composition, we also found, so the blue dots are the healthy controls. These are the people in long remission, the green. Here you can see in red is flare, and brown is in short remission. And you can see that you can separate and you can distinguish more or less a healthy and long remission as compared to people with a flare or short time in remission, and with some statistical difference. But the interesting, there is still some differences between healthy and people in long-term remission. And many of these changes are, as said before, with some oral bacteria being present in fecal samples of people with an acute flare or in short remission. And here is a recovery of many of these fermentative bacteria, including Akkermansia. Interestingly, Akkermansia was the one who best discriminated between short-term remission and long-term remission. And also, very interestingly as well, if you look at the number of weeks in remission, having all the patients here, all the patients in remission, the short-term and the long-term, and here is the abundance of Akkermansia mucinifera in a fecal sample, you can see the longer they have been in remission, the higher is the level of Akkermansia. And finally, it also was interesting that those people with high Akkermansia, well, no, with Akkermansia detectable in feces, because then you will see that over a follow-up period of 2 years, only, I think it was 35 or 36 patients, only 2-3 had a relapse, only 2 had, in fact, a relapse. And here is the people with not detectable Akkermansia in fecal samples, negative for Akkermansia. So half of the cohort had a relapse in a follow-up of 20 years. And this is similar. If you look at people in long-term remission, it's rare that they have, if they have been already 5 years in remission, they might not have near flares, whereas people in short-term remission, again, the 50% of the cohort came out. In conclusions, in IBD, the immunoinflammatory response against intestinal microbes generates lesions of the intestinal mucosa. There is a permanent distortion of the intestinal microbial ecosystem, even during periods of remission, characterized by a reduction in species that produce short-chain fatty acids, the fermentative species, and an increase in non-pathogenic aerobic species with inflammatory potential, some of them of oral origin, as said. Anti-inflammatory and immunosuppressive drugs are effective in inducing remission, but do not guarantee a definitive cure. Here's the point. It is possible to speculate that the intervention on the microbial ecosystem to recover its structure and physiological functionality will be necessary to achieve definite remissions. We are speculating with the concept of microbial healing. Thank you very much for your attention. This is the people who collaborated. This is the PhD from Claudia Herrera, people who collaborate with this study.
Maybe we should look at the conclusion slide again before you turn it off.
Oh, okay, right, good, yes.
Good to keep it here.
Okay.
First of all, is there any question from the audience or the faculty guys?
From the panel.
From the
May
panel.
Yeah,
go ahead,
Fransisco, as I expected, a wonderful lecture again. 2 questions, please. One, when you look for the healing, you took in the, what markers of healing did you use? Mucosal healing or tissue target or transmural healing? And second, according to your conclusions, why do you think attempts to treat IBD with antibiotics or probiotics were not very relevant?
Exactly. So the 2 points are very interesting. So you will see the paper that all people with long-term remission had an endoscopy, and they have a low, not only Mayo score, but also mucosal histological healing, which I can't remember. It's not transmural because this is ulcerative colitis, but in the paper is very well expressed. They follow the usual scores for histological healing and mucosal healing. So mucosal healing, obviously, it was the Mayo score, if I remember well, which is 1 or 0. And I can't remember in the histological healing, but this is in the paper. And then we also have had an endoscopy for those in short remission. They do not have mucosal healing in that time because it was between 3 and 12 months after the last flare. And in the people with active IBD, we didn't have an endoscopy, but it was obvious. It was judged with high calprotectin and the colitis activity index score. So it was the definition of the group. You can see the details in the paper. Then the story is that with antibiotics, you might have a beneficial effect, but it's less effective than immunosuppressant drugs. So there were several studies using amoxicillin clavulanic acid and also the ciprofloxacin and metronidazole done in the 90s. But basically, they were not so good. So they were, it happens the same as with the diversion, the surgical diversion of the fecal stream. You could get some response, But again, when you reconstituted the transit, then there was an immediate relapse. And I remember studies with Fipro and Metro, there was a reduction of inflammatory markers, but once you stopped the antibiotics, you had an immediate relapse. So this really suggests that bacteria are stimulating the inflammation, but the tissue destruction is being done by the immune system.
Yeah. Can I ask a question?
Go ahead, please.
It was really, it was excellent presentation, and the article, I didn't read it, but it's published in the IBD journal, I think.
IBD journal.
Okay, I will look at it. But
okay.
I have two questions or comments. First of all, I really liked your new terminology, which is the microbial remission. It is a very novel concept. I believe we will use it in the future, but the IBD community today not very much involved in the microbiota hypothesis. They are not very familiar with that, or they don't like it too much. But in the future, I think there will be more evidences on this. The second one is, you mentioned that there are some microorganisms coming from the oral part. We are also making, we just performed a study in our clinic, and we are trying to publish it at the moment. We looked at the oral microbiota and gut microbiota correlation in patients with ulcerative colitis. We also find some surprising correlations on that. Actually, gastrointestinal system is not only the gut, it begins from the mouth. It starts from the mouth, and we are also ignoring that part, but it's very important. Thanks for your presentation.
Yeah, you're right. So what happens is that, for instance, Fusobacterium, when they translocate to the gut, they stimulate inflammation. That's the thing. This even if they are anaerobes, they are oxygen resistant, so they can colonize the wall. Whereas Faecalibacterium or Akkermansia, they are very oxygen sensitive. So they cannot attach to the inflamed wall, intestinal mucosa, and they tend to disappear. So, and I agree with you. We need to look about improving the ecosystem in order to understand better the long-term remission. So the mucosal healing theory. This is new, and also the fact that FMT did not work properly. So people in the IBD field is much more interested in immunosuppressing the patient because this is effective, and they forget about the microbiota. This is something that you pointed out, and this too. I agree with you.
Okay. Any more comments? Okay, I think there's none. Thanks. We can now turn your screen sharing. Our last but not least speaker, our good friend, Professor Dan Dumitrasco from Romania. He's from Iuliu Hatieganu, University of Medicine, Pharmacy, Cluj-Napoca. Then your title is Provocating Abdominal Bloating and Distension Guidelines and SIBO. Is there any progress in our daily practice? And we are having a lot of difficulties regarding this topic. We discussed it before in another one of this webinars in abdominal bloating and distension then, and we discussed what the role of SIBO, which is, we find it pretty interesting. There is also, and I believe also there is an abuse, two things together. I would love to learn your opinion. Thanks for joining us. Please go ahead.
Thank you, Serhat, for the kind invitation to be with Turkish friends. And after two wonderful presentations of hard science, let's go to a clinical case. And I selected, as you will see, a bloating situation. This is about a female, 42. She's a stomatologist, dentist, married with one daughter, living in a Romanian urban area. But 2 years ago, she had to quit her job and to follow her husband in a Mediterranean country where her husband, who was a kind of engineer, had a job to achieve. Therefore, she lost the environment she had at home and didn't like it, dreaming to return home around with the family. In these conditions, a year before, so 1 year after living in that Mediterranean city, she complained of battering, bloating, and flatulence, but no other symptoms, no stool alterations, very infrequent constipation, but otherwise not a typical chronic constipation according to Rome Foundation. For her battering, bloating, she's visited several doctors in that country, and nobody was able to find relevant data. She had repeatedly performed blood tests or urine tests, all were normal. A colonoscopy, which followed, was also normal. And so during the holidays, she visited my ambulatory clinic with these complaints. The history, you just heard it. At the clinical exam, everything was normal except some tympany when I performed abdominal percussion. And next was abdominal ultrasonography showing a non-related slump, so mild fatty liver, but also aerocolia. In this situation, we had to think to bloating. And first step is to clearly identify the bloating. There are some countries, Latin countries like mine, where in the Latin languages, we do not have a specific word for bloating. And so people are not able to really identify the bloating. So we have to check with the patients if it's fullness, if it's abdominal discomfort, is postprandial satiety, or is flatulence or belching, or what they call the now remain for the children aerophagia. We have to establish with the patient if the patient has bloating, so the clinical symptom, or has an abdominal distension. You see the girdle from the Rome Foundation slides. And frequently these are associated. Therefore, the Rome Foundation is calling bloating per distension because they are coming together. If we correctly identify bloating, we need to proceed to differentiate for other conditions. And these are happening. Many of you have found in your practice, pregnancy unrecognized, consider bloating. Ascites not recognized and consider bloating. Even the palpation of abdominal mass, or even episodes of intestinal obstruction or pseudo-obstruction. They all have to be differentiated from bloating. And beside this, we have the so-called, we can smile, false pregnancy or pseudo-schiasis. Is actually a somatization, or somatic symptom disorder, the factitious pregnancy. But we have to consider this in females in fertile period. And third is to correctly define the functional bloating. Is it true functional, or is associated to other conditions, and more frequently irritable bowel syndrome? And you see on the left side of the slides that functional abdominal bloating per distension is one of the functional bowel disorders like the IBS and functional constipation and diarrhea. I like to call all this incomplete forms of IBS, where actually pain is missing. And the diagnosis criteria for functional abdominal bloating or distension, you see there, it's actually bloating and or distension in the absence of any other case and filling the usual criteria. So once at least per week, being bothering, and in the absence of other causes or symptoms, present in the last 3 months, onset at the last 6 months, the usual criteria for functional gastrointestinal disorders. Together with the former PhD students, we looked on the association between bloating and IBS during all the 5 editions of Rome, 4 editions, sorry, of Rome volumes, and we could find that 60% of IBS patients may have bloating. Therefore, we always have to ask the patients with bloating if they have other symptoms of IBS. And next, the fifth step is, do we need other investigations or we stay where we are? And then I adopted this algorithm of the ROM4 again. In the presence of a patient with bloating, of course, we have the history, we check the distension, we check the association of other symptoms, we ask about past surgery, diet, as you have seen in the first presentation today, the physical examination, which may show tympany, and then we check the alarm features. And if there are no alarm features, we clearly can consider functional bloating or distension. And then we start to manage the patient with reassurance and recommendations. But if the symptoms are not improving, you see here the blue arrow that I added, we need further testing. And in this case, what testing we should perform in order to decide what to do, we have to look for the pathophysiology of the bloating. And here you see that small intestinal bacterial overgrowth has really an important place. Therefore, we should check most patients with bloating for SIBO. And what is SIBO? One of the definitions is in this review from American Journal. It's a small bowel colonized with excessively microbes normally found in colon. There are also failing control mechanisms like gastric motility, acid secretion, peristalsis, immune defense, clearing measures like saliva, biliary, or pancreatic juice. These control mechanisms are failing. And to define correctly SIBO in quantitative terms, we have to look for more than 100,000 colony-forming units of colonic bacteria in jejunal aspirate. But as we cannot perform jejunal aspirate in any patient, we rely on the breath test. The H2 breath test was the subject of recent European guidelines where we also have participated, led by Heinz Hammer from Austria. You see also the device that we use to identify SIBO in our patients. And our guidelines show that SIBO is characterized by a wide clinical spectrum ranging from mild and unspecified intestinal symptoms to severe malabsorption. And recommendation is that until a true gold standard is established, hydrogen breath testing can be used for SIBO diagnosis. And in other statements or recommendations of our guidelines that we have again published not long ago, we state that the evaluation, these are all voted and agreed, evaluation of SIBO with hydrogen breath test can be considered in the presence of bloating, like in our case, flatulence and so on. We have the methodology, you know, this fasting breathing in disinfected mouse, sampling of exhaled breath every 15 minutes for 2 hours, and we check after 2 hours the ppm. We consider positively more than 10 ppm. Our methodology includes 50 grams of glucose in 250 milliliters of water. Bloating is frequent, and you see here the recent data from the Rome global study where both Turkey and Romania have participating about other 30 countries. And you look here that 3.5% of the general population worldwide suffer from bloating. So in the general practice, you have to expect probably daily at least one patient with bloating. In the gastroenterological practice, much more. And what to do with this lady? On the left, on the right, a nice medieval woodcut with a bloating case. What have to do? I ticked what we have done with our patient, was our medical patient: increase physical activity, low FODMAP diet, psychological counseling, and beside others, adsorbents, antispasmodics, probiotics, alternative therapy. We recommend it as antibiotics, rifaximin alpha, 14 days, 1,000 200 milligrams per day. And we have evidence for this. This is a Lembo study. When you see that after 1 month, abdominal bloating as abdominal pain as well are decreased when we use rifaximin. And this is another study showing that bloating is diminishing after rifaximin in a lot of patients significantly, and this can last even 3 months after the introduction of therapy. So we had arguments and we prescribed to the patient rifaximin. She came back in Romania after 2 months. We controlled the SIBO, which was negative. The symptoms were still present, but much milder, better tolerated. And the patient appreciated better her life conditions. Saying this, I would like to ask you to wait for the next European guidelines on bloating, where the ESNM and Turkish Society, together with my country societies and others, are working. And I have an excellent collaboration with our host, Serhat Bor, for this topic. And I finish by inviting you by the end of the summer to Bucharest is the European Neurogastro meeting. You are all most welcome. Thank you for your attention.
Thank you. Thank
And
you.
yeah, for the perfect presentation. We're gonna go to Bucharest, at least 15 people. Don't worry, we are going to attend. And I'm pretty sure you will be a lovely host for that. Okay, I have a few questions, but if there are other questions, someone asked whether we will put them offline. Yes, we will. The Turkish Society of Gastro recorded all those stuff and sent to European Society of Neurogastroenterology and Motility, and I strongly hope ESNM is going to put it soon in their webpage for offline. If you wanted to just see it, go ahead and look for ESNM webpage. Any question, or do you want me to start?
Can I ask a
question? Yes, Tarkan, please go ahead.
Again, very excellent presentation, Dan. It was really didactic, and now in practical life we face lots of these patients, and actually the main problem is that most of them are female and they have 60% maybe they have constipation. Do you have in your practice any differences to a patient with a bloating or distension according to their bowel habits? For example, constipation is different or diarrhea different? What can you say?
Yes, you are totally right. Most cases come with IBS constipation or simply chronic functional constipation and bloating. Not like this case where the patient has sporadic constipation or don't fill the criteria of constipation. In these cases, we start with counseling the patients, and myself, I have a training in CBT that I use, not as psychotherapist, but I use this experience as in the counseling of the patients. And second, we recommend, besides adsorbents and laxatives, we have also combined drugs involving laxative plus adsorbents. None is working perfectly. And then we also try with some probiotics. Some are working well. You have seen there are some meta-analyses showing which probiotics are better in bloating than others. There are still came, and we will use this during in the next guidelines. So I advise the patient to increase physical activity, to check the diet, to perform relaxation, and to use symptomatic therapy like those I put on the table there. But of course, number needed to treat is quite high.
It's about 10, right, for rifaximin. Actually, Tarkan, if you wanted to say something, go ahead, then I'm going to add.
Fransisco had a hand up.
Yeah.
Fransisco, yes.
Yeah, thank you, Dan. Thank you for this. My concern with SIBO is that most of the diagnoses are done using this lactulose breath test, and which is tricky because in the lactulose breath test, it's very difficult to differentiate whether it is real SIBO or you're just measuring the transit time, the urocecal transit time, because varies as much, because people is being tested after fasting for 10 hours, and sometimes the speed of the transit time from stomach to cecum is quick. So I see that you mentioned that you usually are using a glucose breath test. Okay, this is a good recommendation. Thank you. Because
I appreciate you. You're perfect, and it's very good for our attendees, if they are trainees, to learn that indeed lactulose may induce the peaks, and was respondent for the first data, I guess, from Mark Pimentel, who showed even 40% of SIBO in IBS, as I remember 10 years ago. You're totally right, and therefore we use only glucose. And lactulose, it's not so common. We do not so frequently need to measure the oral cecum transit time. It's not so practical.
So, because I think that is using lactitol or lactulose, there is an overdiagnosis, at least in Spain, and then people receive antibiotics first, is Faximin, then if Faximin doesn't work enough, then Cipro, then metronidazole, and then the microbiota gets destroyed after 1 year.
Yeah.
Let me make a comment. We published with Yantak a few years ago regarding the pinavarium and its role in IBS, but we also perform a subgroup analysis. What we showed that actually pinavariums, is also effective, not as an antispasmodic, but this is also very much effective for the abdominal bloating and distension as well. And I think the number of needed to treat was about 3.43, which is pretty good. By the way, we have a priority because the president of ESNM is asking a question. Kasim Aziz. Hi, Kasim, welcome. How often do you see abdominophrenic dysarthria and how do you treat it? If you wish, we can skip this difficult question.
No, I can answer. I have seen the question and I wonder if you spot this. Thank you, Kasim, for your question. So you are back from Vienna, I understand. Indeed, I do not put so much emphasis as your group in London on this topic, but I take more attention to patients who have belching or eructation. And in this case, I try to teach them breath therapy.
Okay. Breath exercise is also a good way. And when will be ready the next guideline? They're asking. Our abdominal bloating and distension guideline they're asking. When's going to be ready? At least a year from now on, you think then?
I believe it's not so everybody has created their statements.
It takes time. It takes time. It's a difficult.
Eduardo has to push people more, or you, somebody of you.
Yeah.
I have done my task.
And I have a question. You put the FODMAP diet. Do you perform FODMAP diet or gluten-free diet first? Because we have non-celiac gluten sensitivity patients, and I don't know, there is no clear-cut diagnostic tool for those. Then how should we proceed? Which diet comes first?
Nowadays, it's impossible to say something against FODMAP diet. Some years ago, I did a lecture showing how it started in Australia with Crohn's disease, but now it's like a postulate. So indeed, what I have seen in daily practice, many patients want what they call FODMAP. I have to explain to the patient what means FODMAP because many people do not understand what's FODMAP. In some cases, I open the internet and show them the tables with good food and high FODMAP content and low FODMAP to teach to the patients. But I don't trust very much. The people who are sticking to a very strict diet are unhappy people. They are focusing, are hyper vigilant, and I do not think they improve too much except the trial period. But I cannot skip recommending for a low FODMAP diet. That's true.
Agree with you.
Kasim actually commenting your response. We do something similar, but it's a very challenging group. Thank you for your response, what he says. Let me ask the last question, then we finish. Do you think bloating and distension are two different entities or completely the same entity, or in the future, are we going to separate them somehow and treat them somehow?
I think it's the same entity. One is a subjective expression of the condition, and the other one is the objective presentation of the same condition.
Why one is actually is the distended, and the other one is not? That is, do you think that?
Why? That's probably muscular relaxation, and has also importance with the question of Kasim about the phrenic movements. And then there's also the problem with, as the group of Barcelona showed from your group, from Asbiros and Santos, Francis, that the muscles of the abdominal muscles have a deficient contraction, and that is the problem with the transit of the gas in the colon and so on. There are more conditions. Probably is in some the distension is obvious, in others not. It's depending how it is perceived. It's depending how tight are the closes of each patient.
Okay, and last question, what kind of probiotics do you use in SIBO and in which moment of the treatment?
So in SIBO, first I give antibiotics, rifaximin. And if necessary, I can combine with probiotics. Correctly should be a probiotic from the same company. And otherwise, I can use probiotics, including Bifidobacterium infantis. Okay. Or also Lactobacillus plantarum, also working well, but the difference is not so impressive between different. I haven't seen head-to-head comparisons. Have you seen, Francisco? I haven't seen head-to-head between different probiotics, mainly with placebo or standard therapy or so on.
Always. And yeah. Elizabeth Barba, there's a comment from Elizabeth. I think there are two different, regarding the bloating and distension question of mine, there are two different entities. Bloating is secondary to hypersensitivity, and distension is secondary to APD. This is his comment.
Well, pathogenically might be. It's a hypothesis.
Abdominal phrenic dyssynergia. Distension is secondary to abdominal phrenic dyssynergia, but bloating is secondary to hypersensitivity. Actually, I have an intention to agree with her.
Yeah, but what about people who have both?
Then they have both, possibly.
Yeah, both. Yeah.
Or both problems. It's pretty common overlap. Okay.
Good comment. Yeah.
Now let's just on time. Can I see the last slide, please? And we are coming to an end. The next month, we are going to finish with another lovely webinar. Thanks for the whole faculty for this lovely presentation. And what we are going to talk in this next one, please. Next program.
Sorry, there's a problem about my PowerPoint. Just give me a second, please.
Okay, then we are going to talk with, Yantak is going to join us, and we are going to talk about some postprandial distress syndrome and functional dyspepsia. Julian Scholl, Yantak, and Beth Brothers, all from the Leuven team, going to be with us. Thanks for joining, and see you soon for next month, 5th of June, we'll be here, and lovely to see you guys. Bye-bye.
Thank you.
Thank you. See you. Bye-bye.